Welcome, and thank you everyone for joining us. This is a third installment of our COVID-19 vaccine series, and I think there will be additional installments as we move through this pandemic. Previously, we explored the origins and mechanisms behind the novel mRNA vaccines. We debated how we can possibly ensure ethical and equitable access to these and other vaccines. Both of these previous recordings are available on the NYSCF website if you want to revisit them, and I would encourage you to do so if you haven't seen them. We're also putting the links in the chat. So today we have a really extraordinary group with us to engage in the discussion that is top of mind for everyone these days, how we actually end this pandemic and the role of these new vaccines. There's a lot of ground to cover tonight, but I'm sure that we're going to be able to at least touch on what makes this horrific pandemic unique and uniquely challenging, and what the current status of the vaccine rollout is in the US and around the world, and how we are in fact prioritizing access and really the nuts and bolts of how to operationalize getting the world's population back to normal. So I'm delighted to welcome our three panelists. We have full bios and additional resources on the NYSCF website. So in brief summary, let me introduce Dr. Siddhartha Mukherjee. Sid is a Pulitzer Prize winning physician scientist at Columbia, a cancer physician who also trained as a virologist. He's a member of Governor Cuomo's Reimagine New York Commission to Build Back Better. And now I'm delighted to say a member of the NYSCF board. So welcome, Sid.
Thank you.
And I'd also like to introduce Dr. Wafaa El-Sadr, a global health expert, a MacArthur Foundation Fellow, a professor of epidemiology and medicine, and director of ICAP at Columbia at the Mailman School, and really, and actually the author today of a must-read op-ed in the Times that deals with this very topic. And I'm also delighted to introduce Gareth Rhodes. Gareth is the Deputy Superintendent and Special Counsel at the New York State Department of Financial Services and a key member of the New York State COVID Response Task Force. And Gareth has been heavily involved in the vaccine logistics in New York, in testing, and is going to be able to really discuss all aspects of what it means to actually do an extraordinary rollout in this very difficult circumstance, and what the next year might look like as we pull ourselves out of this pandemic. So thank you everyone for joining and sharing your time with us. I'm really grateful. And perhaps Wafaa, could you start with sharing what it is about COVID-19 and the response that has made this the worst pandemic we've seen in our lifetime?
Sure. I can thank you very much for the opportunity to speak with you tonight. And yes, I think there are a couple of, I would say, early lessons learned as to why this pandemic has reached the dimensions it has reached, and also why, in many ways, the response has been suboptimal. And there's no doubt that the response has been very choppy and suboptimal. I think one is that, unfortunately, we did not learn the lessons of the past and we were not ready or prepared to respond to what many of us knew would inevitably come along, which is another pandemic caused by probably most likely a virus. So that's number one. So we had essentially dismantled some of the structures and the workforce that has traditionally been very involved in terms of trying to predict these epidemics, as well as also try to respond to such epidemics. I think another aspect has been the longstanding, for decades now, really underfunding and almost deterioration of, we've let our public health systems really wither over the past decades. Lack of investments in public health, for a very simple reason that people often don't really appreciate what public health does. Public health does prevention, and nobody appreciates prevention. There's much more of a sense of appreciation for healthcare in general rather than public health and the difficult tasks of public health in terms of surveillance and data, and also in terms of contact tracing and many other aspects of that are critical to the response. And then I think also at the same time, there's been huge gaps in our capabilities to implement a variety of different interventions, whether it be in testing or now the rollout of the vaccine. We've had a very bumpy road in terms of being able to put together the step-by-step approach to how do you go from taking an innovation all the way into implementation and scale up. And I think we have had a lot of lessons learned along the way in terms of the need for much more detailed and deep planning and a step-by-step, really detailed planning and dry runs and making sure that every step of the way will go smoothly. And that, unfortunately, again, we have not done that very effectively for a variety of reasons. And lastly is, I think also, we've had challenges in terms of communications, engaging communities and gaining the trust of the most deeply affected communities regarding COVID-19 and also regarding the vaccine. So both the depletion of the resources and the workforce, as well as systems, the weaknesses in our logistical and operation system, and lastly, some of the missteps in terms of communication and engagement of communities, all of these together have created the crisis we're in today.
So Sid, in your view, I mean, we're sitting in the middle of this big mess that everybody is kind of scrambling to respond to. We do have some bright lights. I mean, we do have, the first two vaccines are pretty fabulous. I think better than certainly the expectations of the companies themselves. But actually, the last mile, getting those vaccines into people and making sure we have enough, we now fortunately are going to have an incoming administration that believes in science, that is committed to, it appears, public health. How do we get from where we are to where we need to be?
So again, thank you. I was very moved and provoked by Dr. El-Sadr's piece in the New York Times this week. And I would encourage everyone to read it. A vaccine is a drug, it's useless. Vaccination is a process and it's useful. Going from a vaccine to vaccination is what we need to do. We have vaccines now available. We need to vaccinate people. A vaccine sitting in the freezer is a useless vial. A vaccination in a human being is a useful thing. Let's talk a little bit about that transition. First of all, we don't have enough. And we don't have enough because of lots of reasons, but one of the reasons is that we didn't invest in the infrastructure that is required as a nation. We didn't invest in the infrastructure that's required to produce these vaccines at a level, 200, 300 million people, and potentially, as Dr. Sadr pointed out, in the case of drugs for HIV, potentially for the world. We did not invest, and now we are scrambling backwards to invest in the infrastructure to produce the vaccines themselves. So there is a production limitation, which is the first step. So we need to solve that limitation, and part of the vaccine task force that comes into the new administration will have to address how to overcome those production limitations. That might range from using presidential powers, including vaccine task force powers, to enable Moderna and Pfizer and potentially Johnson & Johnson and AstraZeneca. Remember, the first two are approved under EUA. The second two are in submission or have not finished their phase 3 trials, to be able to produce enough vaccines. That's step one. Step two is the logistics. So that is being controlled at a federal level. And we can talk through all the logistics of all of that. Step two is the movement of the vaccine once it's been produced in the factory to the delivery sites. Now, because we are a federal system, and there are problems and advantages of the federal system, I'll talk about both of them. The movement of the vaccine to the states has been delegated to currently Operation Warp Speed for the most part, which is the federal aspect of the system, and is being controlled by subcontractors of the federal system to move the vaccine to the various sites. Thus far, we've been analyzing this, I've been analyzing this. Thus far, that does not seem to be the bottleneck. We've been able to move the vaccines. These are tough vaccines to move. But Pfizer has to be stored at minus 80 degrees, Moderna at minus 20 degrees, and then subsequently at freezer temperature or fridge temperature. But nonetheless, these are not easy vaccines. Both of them require double doses. We'll come back to that in a second. So that's step two, and that is still a federal responsibility. Step three is the most complex. Step three is a state responsibility. Once the vaccine arrives at your local, what I call local hospital dock, DOCK, or at your Walgreens or wherever it might arrive, it is now the responsibility of the county and the state to dispense of the vaccine as it arrives. If we had full capacity, in other words, if we had no limitations on the number of vaccines available, we would do what was done during the smallpox pandemic or other pandemics that have been in the past, which is we would say, come one, come all. Here's a kiosk in Chelsea. Here's a kiosk in Chicago. Here's a kiosk wherever it is. Come one, come all, come and get the vaccine and you're done. But the realities of these two vaccines that have been currently approved under the EUA process are the following. Number one is that there are limitations in terms of the total number available. So that's one limitation. And number two is that there is for the first vaccination, a 15-minute observation period that you need to go through to ensure that you don't have an anaphylactic or allergic reaction to the first vaccine. 30 minutes if you've had a prior vaccine allergy. That's for the first dose. And number two, of course, we don't have enough. So therefore, under those two circumstances, the vaccination becomes now no longer a 2-minute job, but it becomes at least a 15-minute plus another 20-minute job, right? Because you're screening and making sure that people are getting the right vaccine at the right time. So it now becomes a 40-minute job as opposed to a 3-minute job. And you can imagine that is a 10-fold change in the total amount of time that a person has to wait or has to be vaccinated. And number two is that we don't have enough. So therefore comes the question of rationing and figuring out who needs to be rationed and who doesn't need to be rationed. And the last point I'll make here is that puts us in physicians like me, puts us in a very difficult position because we may need to make decisions, not just about the logistics of, how many vaccines are being produced, federal decision, how many vaccines are being moved, federal decisions, but how the states will ration the amount of vaccine or the number of vaccines and ration the number of slots for vaccination that are available over time, state decision. And that has been it's been now 7 to 10 days. It has already been an enormous problem. And that is the problem that we're trying to address. Should we vaccinate people over 65 first? Should we vaccinate healthcare workers, frontline workers even before that? What about firefighters? What about policemen? What about teachers? What about any of these all categories? If we had infinite supply, this problem would go away. But we don't have infinite supply, and we have infinite demand, and that's the problem.
Well, in a certain way, which we'll get into, we have something a little less than infinite demand, right? Because we do have the problem where even at the major medical centers, we do have people who are declining vaccination for whatever reason, not just because, in the case of a woman who is pregnant or trying to become pregnant, where the data is, is not definitive yet.
We'll certainly come back to that. Yes.
But it definitely is an issue. So Gareth, here you are. It's not for you. It's not at all hypothetical. You are charged with trying to actually get these vaccine stations set up, with trying to get trying to adhere to whatever the thoughts are on a particular day, because it does seem to change daily or every few days of how we're going to prioritize. So you have been sitting in the hot seat of that, and why don't you talk about that from your vantage point?
Great, and thank you, Susan, and thank you to the New York Stem Cell Foundation for having us and hosting this tonight. It's Sid raised some, I think, some very good points about the logistical challenges that are facing states and localities around the country. I think a month ago today, December 14th, was the first dose administered in the nation here in New York at a hospital in Queens. If you think back to where we were on that day, the CDC had just come out with their recommendations on who should receive the vaccine first. It was a very small, narrow group of people, which the ACIP recommended: healthcare, frontline healthcare workers, residents and staff of long-term care facilities. In New York State, that's about a population of about 2.1 million. We received about 170,000 doses in week 1, slowly ramping up after that. The conversation, if you remember back kind of when that was beginning, was really that strict priority. Is it going to be ICU and emergency department before others who maybe aren't quite as much on the front line? The conversation shifted properly and rightfully so over a period of weeks from why are there still doses in inventory when they could be going into arms? So we went from on December 14th, just here in New York, 2.1 million people eligible, to today, over 7 million people eligible. And that's not even including yet the recommendations that were made this past week about adults under 65 with underlying health conditions. And you're talking, if you look at the state population who is 16 and older, it's 15 million people. So we currently have 7.1 million people eligible out of 15 million. And that in that time period, we only received 1 million doses for first doses, of which we have administered approximately 700. We received 1.1 million, of which we've administered approximately 700,000, including the long-term care facility program, which the federal government is running. So if you look at just the allocations that New York State has under its control, we've received about 850,000, administered about 600,000. It's about a 72% administration rate. And you've seen dramatic uptick in terms of throughput from beginning in week 1. Just some of these statistics. This week 1, we administered about 34,000 shots. Week 2, 98,000. Week 3, 143,000. Just last week, 300,000. Last week, more shots administered than came in the door. And we're well on our way to beating that this week. So I think you've seen the different chapters of the vaccine rollout, from this strict prioritization to really the focus on throughput, getting shots in arms right where it should be. How do we clear the shelves at the end of every single week? And with that, you sacrifice. You're gonna have, and we get calls all the time from people who were in that very first category saying, now we can't get an appointment, or it's harder to get a dose. But we are really seeing these shots go off the shelf in a way. And I'm sure we all saw this week the Javits Center opening. Many local health departments are opening mass vaccination sites, and there are certainly some logistical and operational hurdles to this. Schedule, when you open up to 7.1 million people and need to schedule all those people and everyone's calling at once, these are certainly large challenges on a public health infrastructure that has been severely taxed, to say the least, over the last months. So I think what we're looking at is between 200 and 300,000 doses coming into New York a week right now, with an eligible population of 7 million, with 700,000 administered so far. At this pace, we're looking at 6 months, really, until even that group, even taking into account hesitancy and other factors. So it's, but again, this is their patience is what we've been asking New Yorkers for, but it's been really, to me, for someone who, I remember in late March setting up the Javits Center as the temporary hospital and seeing the comfort come up the Hudson River there, and just now seeing those shots in arms. It was an emotional day, just seeing how that transformation has happened, and really, at least for me, I know for many of us, a sign of hope for what's ahead.
You know, one of the things I found very disturbing, which I gather is now changing, is there was such a concern initially from making sure that only those in the categories were vaccinated, yet the human behavior and actually the vaccines themselves, because Moderna has a lifespan of 6 hours after it's been thawed. I don't recall exactly what the Pfizer is, but you know, pharmacists or facilities really, you know, terrified. They didn't want to incur penalties or lose their license, but you know, they're deciding between, you know, grabbing somebody, a human being, and vaccinating them, right, better than throwing it out, or what some of them ended up doing, which was throwing it out, which is just, to me, criminal. And when I look at some of the categories that haven't yet been put into play, but are people under 65 who have particular conditions, you know, there again, you know, for example, even in diabetes, for some reason, type 1 diabetes seems to have been prioritized lower than type 2, when in fact it has a higher risk. I mean, it's kind of the, you know, the perfect being the enemy of the good, with all of this slicing and dicing, doesn't really correlate with human behavior, because people don't come, you know, sort of in sets of 10, right, which is the doses in a Moderna vial, or whatever it turned out to be, and, you know, sort of arm in arm saying, let's get vaccinated. They show up, or things happen in their life and they cancel, or they're late, and, you know, you've got people, you know, waiting, just desperate to figure out how are we going to use the supply. So I think that I'm very pleased that the regulations were eased a bit, and I hope that the messaging is really a goal. But in fact, at the end of the day, just let's not waste the you know, this really precious material. Wafaa, what's your?
Yeah, no, I think it's a very good point, Susan. I think it's interesting to reflect that. I mean, there is really, or there certainly the U.S. and I can think of other countries that have had a successful adult vaccination programs. I mean, I think countries like the United States and many countries around the world actually have done pretty well in terms of childhood vaccination, and largely because you're required to have your child vaccinated to go to school. But for adult vaccination, we don't have a good track record. We don't have the systems to have done adult vaccination. Every year, maybe 50% of people who need the flu vaccine actually receive it. So we don't have a systematic way. We don't have the playbook by which we can massively vaccinate adults in this country. And I think that's part of the problem. It's kind of it's new for everybody. The other issue is the different priority groups. And that has been quite a challenge, because obviously that adds complexity, and then you have to require people to show evidence of their eligibility. I mean, somebody coming in, they say, do they have to get a doctor's note that says they have diabetes? Do they have to? It adds complexity to already a very complex process, which is
an emotional process.
And it's an emotional process, and
a scary process.
And I think in many ways the whole idea of trying to have these priority groups was based on very good intentions, and the intentions were to preserve equity, which is really important, that those who are may have been most severely impacted by this epidemic should be at the front of the line, and also to try to prevent disease and death. And that's going to populations that are at high risk, and they have a high risk of mortality and morbidity. So the principles are very solid in terms of actually what drove the prioritization. The problem is that reality clashed with the principles, and it became clear that it is, while these are really very great motivations for doing it right, it just is very hard to deliver on this. And I think in many ways, I feel that maybe another approach might be at this point in time. I want to preserve equity because it's something I deeply believe in, but maybe what we can do is try to get at equity by where we situate vaccination centers, where we have them based. And then you can maybe have, decreasing kind of age bands, that we go down different age bands and get at equity through let geography guide equity, or not just geography, but maybe even different workforce, like set up something at the bus depot down the street. So I'm thinking that it might be that what is the perfect can be the enemy of perfect sometimes can be the enemy of the good, is maybe now, we maybe these kinds of imperatives are forcing us to revisit some of these very, very important and lofty principles that guided this prioritization scheme.
And you've been involved in setting up a mass vaccination.
I have, and I can talk to you about the challenges about that in a second. So one of the setups that I've been involved in has been the Disneyland Superpod. And it's been, I have to say, an incredible challenge. Challenges that we have not even observed before. I'll talk about some of them, but first of all, let me echo Wafaa's thoughts. I'm going to take everyone is a doctor, so I'm going to use everyone's first names. I'm sorry. I think it's incredibly important. The first thing that was very important was to get the frontline workers vaccinated. I think no one debates that, because they were in the front lines, nurses, physicians, people who cleaned the rooms, people who were in the hospitals. I would say that there is virtually no doubt. I had a conversation with Peter Singer and Juliet Kayyem and others in the New York Times Magazine. You're welcome to look at that. No one challenges the idea that these frontline workers need to be vaccinated first. That's the easy part. Then comes the hard part, which is how do we get to the disproportionality of deaths among African Americans, Latinx, and other communities which have suffered disproportionate amounts of death. I think one solution is to increase vaccination, what I would call, as Wafaa might have described it, vaccination visibility, which is your neighborhood kiosk, not Walgreens necessarily, but a neighborhood kiosk should have a vaccination site, clear information available in all languages, particularly languages that are local, and have those vaccines available should you desire to have a vaccine, because they have been disproportionately affected. That would be one thing. I will come back to the Disneyland pod in 1 second. But the last thing I want to mention, and this is a credit to some extent to Gareth and others, there's been a lot of news about vaccine wastage and a lot of news about people giving inappropriate vaccination, etc. In fact, if you look at the numbers, they're actually quite small.
Yes.
The US has not wasted, so far we haven't wasted a lot of vaccine, and the number of, I would say, criminal acts or out of turn acts of vaccination, although they have been reported in the newspapers and are real, I'm not debating them, are relatively small. We have largely followed protocol and are largely following protocol, and we have to, because we don't have enough. If there was an infinite supply, we could unleash it. There is not an infinite supply. All right, Now let me speak a little bit about our experience in the Disneyland Pod, because we are vaccinating 10,000 people per day, which it's the largest, one of the two largest pods available. The problem with this vaccine, as it is right now, is that it requires 2 shots and it requires a 15-minute post-vaccination observation period. That is unlike the flu vaccination, it's unlike MMR, it's unlike TDT and other vaccines that children get. You know, if you get MMR, you go get a jab in your pediatrician's office, you leave and you're done. This requires, as far as we can tell, a pre-registration to make sure that you're eligible because of the vaccine limitations. Consent, of course, there's always consent, followed by a vaccination itself, followed by a 15-minute observation period in which you make sure that you don't get an anaphylactic shock. That is then followed, Moderna 28 days, Pfizer 21 days, a booster shot for which you have to come back for, presumably at the same site, and then get a booster shot so you don't mix Moderna with Pfizer, Pfizer with Moderna, and as new vaccines come online, AstraZeneca, Johnson & Johnson, you don't mix one with the other. So these present enormous logistic challenges. Gareth knows about all of them because their office has been handling these logistic challenges. What we proposed in the SuperPod in Disneyland is at least get your first shot. At least get the first shot, and then get the first shot. Once you get your first shot, you can get your second shot at your local Walgreens. You could get your second shot at your local kiosk. But at least let's get things moving, because we have 400,000, 500,000 vaccines allocated to California, and of which 20,000, 40,000, et cetera, are in Orange County, where Disneyland is. So my suggestion is to move like Israel has done, which is to say, take all the vaccines that are available, distribute them according to state populations, and then as fast as possible, use technology. We are living in the 21st century. Use technology, because this is a very special vaccine. 2 doses, 15 minutes, all of this stuff, some clinical pre-assessment. Use the technologies that we've made available, including the internet and digital technologies, iPhones, etc., so that we can distribute the vaccine equitably, but also quickly. Because every day is a day that we lose 4,000 people, 3,000 people to the virus, number one. And the second thing I want to talk about, not in this immediate moment when we come back, is that every day, not only are we losing 2,000 or 4,000 people, there are new viral variants that are coming up that are worrisome. And if they're vaccine resistant, and if we don't decrease the so-called R0, or the infection ability of the virus, we will be in a losing game behind the virus. The last thing I'm going to say, Susan, and I'm going to stop, is that there are many vaccine pessimists, and there are many people who are have raised doubts about our capacity to vaccinate. Given the pace of infection, if we do a good job with vaccination, and that's a big if, in other words, if we can vaccinate 100 to 150 million people by, on the order of, let's say 25 million per month, 26 million or 30 million per month, we could potentially see the end of this by April or May. That will be an enormous success. If we don't do it properly, we stretch out into the next summer, potentially into the winter.
Well, I'm going to stay with the optimistic front, and I want to congratulate Gareth and the governor on getting these mega centers set up in New York. The Javits Center, Jones Beach, SUNY Albany. I know the ball fields are coming soon, both the Yankees and the Mets. What is the capacity of those centers? Assuming we had all of the vaccine that we needed, how many people could we in fact vaccinate?
New York State, we could, the Javits Center alone, we think we could do 25,000 people a day over if we ran it 24/7, which would take up about, it's 175,000 doses just for the Javits Center alone, which is in some weeks is larger than the entire amount we've received outside of the long-term care facility federal program. So there's enormous, I think the conversation as it shifted over the last month from kind of this very strict eligibility criteria, making sure the right people are going first. I think it's going to shift in the next weeks when you start having states who have used up 100% of their inventory. It's going to shift toward really more of a scheduling operation of how do you, I think people, I have people who are in my family who I know who are eligible who say, I know I'm not going to get it until March, but at least the fact that I have March 11th at 4 p.m. at the SUNY Albany drive-through locked in, that gives me at least, I reason to hope. The problem is going to be if you have then a large influx of supply that above what we're expecting, all these people want to, of course, reschedule their appointments. So, you're gonna you look at some of these county health departments and some of these mass sites. You can, as Sid was outlining what's happening in Disney. I mean, you can really drive massive throughput, but it has to be, as Wafaa said as well, you have to also this approach where you're in the communities where you're seeing hesitancy rates, where you're seeing where many of the frontline workers live and who aren't getting vaccinated. I think this is where you need to have, even if it's not massive throughput in public housing or massive throughput at churches or community centers or federally qualified health centers in some of these rural communities, even if you're not seeing thousands a week, a couple hundred a week there has an enormous impact in the community.
So what do you see, what is the gap between the amounts that, and I'll just stick to New York, that New York is receiving and what it would be possible to receive from the currently approved manufacturers? Do they have more doses that could be delivered?
Well, they're holding the second dose. So we have not received any second doses outside of the administrative period. So they have we received last week exactly the same number of doses for second shots that we received in week 1, December 14th to the 21st. So that is, they are sending, this doesn't come from Pfizer and Moderna to a state warehouse and then we divide it up. It goes directly from Pfizer and Moderna to the provider. So there's no, we allocate it. There's a federal database called Tiberius that we go in and we say, here's all the different sites around the state that are to get how much vaccine. It ships directly to them using those federal contractors and subcontractors that Sid was describing. And so that they get exactly the same amount, those same sites automatically 3 weeks later for Pfizer and 28 days later for Moderna. So we don't even play a role in that. It just happens automatically. What we have issued guidance on and directed providers to do is make sure when someone is either scheduling their first appointment or getting their first dose, you're scheduling them for their second dose. And we have everyone in the state, every single vaccination dose has to be reported to our centralized system with an email address, a phone number. We have a system where people are texted a reminder about their second dose and email. And if they don't get it, a follow-up system. So we're using these different technologies to try to make sure people do come back for their second dose.
There's a big debate, Susan. There's a big debate in the epidemiology community, and Wafaa and Gareth, please weigh in, whether we should release the first doses en masse, even without waiting and sequestering or keeping back the second doses. Remember that there are two pieces of data that are relevant here. One piece of data is that the clinical trials for Moderna and Pfizer were performed with a 2-dose regimen,
Right.
a first dose and a booster regimen. And I'm a frontline medical worker, so I received the first dose and I'm scheduled to get the next dose next week. that was the nature of the clinical trial. But thankfully, because of a lot of us who were on the boards of various clinical trial adjudication committees, we also asked both Pfizer and Moderna to actualize the level of protection given by the first dose itself. That data is available. You can look it up in the New England Journal of Medicine publications for both Pfizer and Moderna. I'm happy to post them at the NYSCF website as needed. So it turns out that after 14 to 21 days of the first dose of both Pfizer and Moderna, you get pretty reasonable levels of protection from the virus. And I said, remember, after 21 to 14 days. So it's not as if you get a vaccine and magically you're immediately protected from the virus. It takes some time for your immune system to respond to the vaccine. Once the response is established, it takes 14 to 21 days. But after 14 to 21 days, you are indeed more than marginally protected against the virus. And there's a brisk debate going on in the epidemiology community whether we should just release all the vaccine doses that are available so that we can at least get protection, even if it's partial protection, versus whether we should follow the clinical trial, which would provide the full protection as determined by the clinical trial. I have heard now many times, because I've been in contact with the administration, the new incoming administration, that they are leaning towards the prior category, not the latter one, which is release the doses and, say Hail Mary and make sure that by 28 days for Moderna, 21 days for Pfizer, we will get the second dose out. And if we don't get the second dose out, it's a Hail Mary. I am not the biggest fan of that approach, although I see the logic of it. And I'd love to hear what the other panelists have to say about, should the better be the enemy of the perfect, or should we aim for what the clinical trial originally was designed to assess, which is a 2-dose vaccine.
And Sid, can you tell us what was the efficacy that was reported?
So I can't tell you off the top of my head, but by 21 days after, let's say, either Moderna or Pfizer, you got up to the high 80% levels of efficacy. And then the booster, of course, got up to the 95%, which was the reported efficacy in the final trial. So let's take a number. I don't know the numbers off the top of my head. Again, they're available. I'm happy to post the actual graphs in the journal. I spoke directly with the developer, the CMO of Pfizer. I've spoken directly with the CMO of Moderna. Again, those numbers are real numbers, but they're in the high 80s, reaching high 80% levels of protection from the first dose. Again, reaching out into the 21 days. Now, remember, the epidemiological community, and Wafaa, you might be able to talk a little bit about that. Remember, with MMR or with TDT or any of the other vaccines, the booster shots aren't until 1 year or 6 months after the first shot. This is a very particular, very special situation in which, because of the nature of the pandemic and because we wanted to stack the odds towards success, we enabled a 21-day or 28-day booster. That is very unusual for most vaccines. It is not the usual case for vaccines. And for Gareth and others like Gareth, it sets up a larger headache because, of course, 21 days and 28 days is not 6 months or 8 months. So there is a brisk debate going on right now in the epidemiology and science community saying, should the perfect be the enemy of the good? And if we have limited doses available, what should we do? That's one debate. And the second debate is, should the president use, the president-elect, because of the multiple errors that were committed by the prior administration, which we hopefully will not go into it because it will take up the entire hour.
Mhm.
But as the new administration takes charge, should the president-elect use his authority and emergency powers to unleash them on the production of greater vaccine numbers, using all authority available. Wafaa just wrote about this in the New York Times, and thereby supply not just the United States, but the world with the vaccine. So two questions. One question is, where does the epidemiological community and the biological, immunological, virological community, which I'm part of, fall on just saying, let's vaccinate as many people as possible and do a Hail Mary and say, let's wait for the 21 and 28 days? And the second question is, to what extent should the president and the incoming vaccine task force say, let's go for it and let's start making twice or three times more vaccine under emergency use authority powers?
Well, a question is, Wafaa, everybody who is listening to this conversation wants to know, when are we going to be able to get back to normal? Will we be able to get back to normal? And I would appreciate it if you would speak to that a bit. And which of these strategies do you think is going to get us there faster?
It's a tough question, but a very important question. I always think that in order to achieve the impact, the desired impact of vaccines, you have to optimize two things. You have to optimize, number one, the uptake of the vaccine by your community, by the population. So that's really critical. We need to get very, very high uptake to get the benefits of a vaccine. And the second thing you need to optimize is the efficacy of the vaccine itself. So ideally, if we had vaccines like the Pfizer BioNTech and the Moderna vaccines with more than 95% efficacy, that's fantastic. So here we have covered one of those factors, the efficacy piece. So now the challenge is uptake, is how do we get to very high uptake in our communities, in our populations? And that's really what's going to determine our ability to gain the benefits of these vaccines. And we're in a race, we're in a race between increasing vaccine coverage as quickly as possible and a race against the spread of this virus. And then there's also the threat of these new variants that people are worried about, that may, as this virus spreads from one individual to the next, of course, people develop COVID-19, but even beyond that, that offers an opportunity for the viruses to mutate, to change. And the concern is that if you keep on getting transmission, that you will have a mutation, and that mutation may be associated with more severe disease or may actually be able to escape the vaccine. So that's why it's really important to use the vaccine to our best ability now to achieve the highest coverage. Because with 95% efficacy, if we can get to 80% coverage, 90% coverage of our population, I think we would be in good shape. We would kind of hopefully stop a development of COVID-19 and hopefully be able to then go back to normal. So a lot of it is kind of, I feel, our fate is in our hands, of course, we have to continue, even for people who get vaccinated. It is very, very important to remind everyone that even after you get vaccinated, you must continue to observe the current protective measures that we know. The face covering in particular, the masking and the distancing, those are the mainstay two measures that we have to keep doing. And the reason for this are a couple of things. One is that we don't know yet if these vaccines prevent infection. We know they prevent COVID disease, they prevent symptomatic disease, but we don't have definitive proof as of yet that they prevent infection. Meaning that I could be vaccinated, I could be infected, asymptomatic, I don't have any symptoms, and then if I'm not wearing a mask, and I can unknowingly transmit it to somebody else. So we need to continue to adhere to these measures that we've been talking about for the past year as religiously as possible, while at the same time doing our very best to increase coverage as quickly as possible. And I understand the logistical concerns. Gareth, I totally understand all the complexities and so on, and also the nimbleness and the adaptability and so on that's needed to be demonstrated in expanding access. But at the same time, we also can't forget the hesitancy that exists in our population. And that means engaging communities and community leaders, community champions. And I wish that we had started doing this from July. I mean, we knew vaccines were coming down the line.
I can't agree more, Wafaa. We are late to the game.
We're very late to the game, and we could have started this way back to start to engage the communities, engage the leaders, the respected champions, and
However,
for the vaccine.
I must interject. We are where we are. So I think we can do the postmortem when we put the we put the pandemic to rest. There are so many things that we all wish had happened, but here we have Gareth representing New York and the governor that's taking a very aggressive approach to trying to control this pandemic. I myself go back and forth about the completing the dose, not completing the dose. I mean, Gareth, I think from your perspective, do you feel if in the rollout as you see going forward, is it, as Wafaa has said, making sure that we've got the vaccination sites in the areas where we are going to reach populations that have been disproportionately affected? Do you think that's one of the most effective things that we can do? I know you've emphasized that a lot.
Yes, and I'll just briefly speak a little bit about, I think, as well, before I answer that question, about if you look at where the COVID, like the UK was given the situation with their hospitals, with their increasing cases, was faced with a situation that is, I think, different a little bit than what we are facing here. You look, New York, for example, this past week we had our lowest hospital rate growth since late October. Our positivity rates are coming down. It's pretty clear there was a Christmas, New Year's spike, and there's been a plateau and a decline since then, which is great news. That could, with these new strains being discovered, this could obviously change very quickly. The UK strain, I think, was discovered in September 1st, before seeing what happened 3 months later. I think it's very important that the genomic sequencing that's happening both in the public health labs, private health labs, we have to really pay close attention to these new strains, because that could impact the decision about what to do with the second dose. I think in terms of capacity wise, New York State does, this is not the state government, but New York State, about 10 million people get the flu vaccine over 5 months every single flu season. You do the math, that's 500,000 shots a week. We did 300,000 the COVID vaccine last week, and then we're talking using these massive centers. We don't use the Javits to do flu vaccines. We use the pharmacies, your doctor's offices. Throughput here is going to be, it's there. We can build it. We are building it. It can happen, and it's exactly, Susan, as you mentioned, it's both the large sites to process tens of thousands of people a day all over the state. No vaccines on the shelf. It's also the geographic reach, going into the communities, the churches, community centers. Big priority for the state. You'll see, I think, some announcements over the next couple of days on that. And it's an all of the above approach. This is an absolute war effort. I think one thing the governor has been saying from the very beginning was that we need more federal support, because every one of these states and local health departments and hospitals and our existing healthcare infrastructure has been pushed to its max for the last 8 months. I mean, we're asking the same infrastructure to take on a logistical and operational challenge that is as challenging as testing and building emergency hospitals. And we're asking the same people and the same infrastructure to do it. So that's what we've been asking. And this bill that just passed Congress finally allocated more money to the states to do this. But there was, I think, just like, as you could argue throughout many parts of the COVID crisis, there was an enormous opportunity for the federal government to play a much larger role here. And instead it was, a lot of it was left to the states and local governments, which I think is partly to blame for what you've seen in the last couple of weeks nationwide in terms of the number of doses that are going into ours.
Yeah, no, and basically,
bulk of the work was done by nursing staff and by doctors. So I think I would not be remiss in declaring 2021 the year of the nurses.
Absolutely.
Because while we sheltered in our homes, they came out every day and took care of patients, and are now coming out every day and vaccinating people. So anyway,
I think there's absolutely, and I'm very excited about the core of 1,000 public health workers. I mean, perhaps this will begin. We will begin to see infrastructure. We have crumbling health. We have crumbling bridges. We have crumbling tunnels. And as the governor just opened this incredible train station, Moynihan Station, for the, that has been, 30 years in conversation, that, hopefully this will be a time where we can, maybe it's taken this pandemic, but, with the incoming administration to do something about it. We have a lot of questions coming in. I've tried to incorporate as many as I could. But I think one is very, very important. We've made this point in this conversation, but I am worried. I don't want people to think that they get vaccinated and it's a get out of jail free card and they can rip off their masks and fly where they want. So I think we don't want to create, you get right, exactly. You get vaccinated, well, mine's not in my pocket, but you get vaccinated and, and you become an asymptomatic super spreader. So we must continue. I mean, Wafaa, you're the, the epidemiologist, but I mean, I believe that you get vaccinated, Sid, you get your second shot tomorrow, but you're still with your mask. You're still not eating indoors. So I think it's important to state that. And the other question, which, because we don't know, I think we can say unequivocally right now, we don't know after you're vaccinated if you are still able to transmit the disease, right?
We still don't know if the vaccine prevents you from getting infected and therefore potentially could transmit the disease, correct?
Yeah. Although very early data from Israel would suggest that the transmission decreases. I would emphasize it's very early data. It's not been published yet, but very early data from Israel would be in the positive direction. I would also emphasize that the B111 strain, which is the strain that's maybe 70% of London, is probably vaccine sensitive, which means that it will be prevented by the vaccine. The E6 strain, which is from South Africa and in Brazil, is still in evaluation. So the bad news is that the B117 strain, which we have in the United States, has a greater level of infectivity, but doesn't seem to cause worse disease. That's the good news. Well, it's bad news and good news. The E6 strain from South Africa and from Brazil may be less sensitive to the vaccine, although we don't know that yet for sure. And that is something that's a question that we're finding out. So all of these reasons, number one is the fact that although early data from from Israel suggests that there is less transmission. Number two, that there are at least two strains that are now moving through the population, as they will even inevitably because of viral evolution. There are two strains that are moving through the population that have a higher level of infectivity, and another one potentially a possibility of vaccine resistant. We are not going to ask people to stop masking and using social distancing in the near future, at least until we see the curves of mortality and infectivity change in the United States. And I think that's a fair statement, Wafaa, Gareth.
So I just want to turn to the children.
Yeah.
We have children not in school. It's absolutely terrible. Thank goodness their teachers hopefully will take the opportunity to get vaccinated. I understand that I believe it's I forget which one of the companies is now doing trials on kids 6 to 12. So far, it looks as though the children are getting infected at lower levels. But the vicious cycle of parents not being able to work, the daycare centers and the schools are a critical part of that, and the children and parents that are really suffering terribly. And I know that a huge effort on the part of the state is to try to get kids back in school. Do we think this is something that, in a world where all the teachers are vaccinated, but the children cannot yet be vaccinated, do we think that we're going to be able to return our children to school, when September comes? I mean, it's, what do you think, Wafaa?
I actually think we have some reassuring news in terms of schools, and particularly for the younger age schools, children. And there's been a lot of evidence, some evidence from the US and evidence from other countries as well, that demonstrates that actually transmission within schools is quite low, and the transmission from children to adults is quite low as well. So that's reassuring. And I think if you look at even some of the data based on the testing that's been going on in schools here and elsewhere, is that often these infections that have been identified from transmission in the community rather than transmission in the school. So I think if we can, while we're waiting for results on the safety of these vaccines in children, and these studies are only looking at safety, they're not powered to look at efficacy. While we're waiting for these safety studies, which are not going to be long studies, they're going to be short-term studies, is that I think vaccinating as many of the school, not just the teachers, but also the staff in the schools, all the people who work in the schools, is a very important priority. And that's what's going on now, as New York State has prioritized any staff, including teachers working at schools.
Cafeteria workers and janitors and so forth.
Can I add one more thing to that, which is that, there are, this is me speaking as a virologist and an immunologist, not as an epidemiologist. I do think that it's for the economy and for the welfare of many, many people. Of course, it is important to get people back into schools. The virus has disproportionately affected some communities. It has disproportionately affected African Americans, Latinx communities, and it has disproportionately affected women. I mean, the New York Times has a recent article which shows how much the disproportionality is. Of the 156, if you take 156,000 jobs that were recovered post this virus, 140 or 142,000 of them are of men, and 16,000 of them are women. So there's a 10-fold discrepancy, give or take, between the return of women to the workplace versus the return of men to the workplace. So I appreciate all of these efforts. 2 points to make. Number one is that in general, other coronaviruses, of which SARS-CoV-2 is one, do not, and we haven't looked so deeply because we haven't looked, but do not seem to show long-term effects in children. They suffer a common cold, they get back, and they're fine. But we don't know because we haven't looked, because we haven't compared. Number two is this coronavirus special? In other words, could we be ignoring something about asymptomatic infection in children that would be worrisome? And so I would, in the next few months, weeks, days, I would encourage immunologists and virologists, pathologists, etc., to explore that question very deeply, so that we can be reassured that even if children were infected and suffered an asymptomatic infection, as you know, the mortality rate in children is vanishingly small, very, very, very small. So even if children are infected, if we can be reassured based on pathological and other criteria that even if they were infected, much like other coronaviruses, this is a common cold. It affects, the virus infects the heart, the virus infects other parts of the body. So it's not a trivial matter, but the children clear it and the children move on as children do. It would be very, very reassuring then to vaccinate the teaching population, which is much more at risk, and move on, open schools, and thereby allow people, mothers especially with masks, to return to work. This is a big task, and this is a kind of task that the Vaccine Task Force and the National Institutes of Health could take up. It is a task that involves epidemiologists and immunologists and virologists and pathologists, but this is the kind of things that the United States actually does quite well.
And pediatricians. I think that that's going to be the topic for our next panel. I'm afraid that we've come to the end of our time, but I have one question, which is something that has bothered me from the very beginning. I know, Gareth, it's something that you've been involved in, which is, can we have a test that is a simple saliva test that is very cheap, there's a few cents, that every day we can check our own status and we know whether we're safe to go do whatever activities we're going to do or not? Can I give my grandson a hug? Can I go to my workplace? Can I see my friend for lunch? When will we have that? We know of a number of efforts, Sherlock and others, to do this, but that just seems the way we can test our blood sugar with a test strip, pregnancy with a little bit of urine, and there you are. When will we have a test, and is this something that that is part of the toolkit that you envision, as you're opening hospitals, closing hospitals, opening vaccination sites, opening testing centers, et cetera?
Susan, I think that's absolutely right. I think also as the vaccine rolls out, as we think about reopening the economy, even with the virus here, we actually, my personal opinion, not speaking as representative of New York State, is that we have to rethink how we as a society think about testing, less as a tool to say, yes, I am negative or yes, I am positive. I mean, most of the testing that happens in the country right now is PCR lab-based testing, where you could get tested at 9:45 in the morning, your samples off to the lab and run the next day. You could be infected 15 minutes later. So I think to reconsider, there's a lot of extraordinarily cheap point of care antigen testing on the market that has extraordinary limitations when it comes to all sorts of health purposes. But the beauty is that it's cheap. It can be done without having to be sent to a lab. Rapid result. You will have to account for false positives. You have to account for false negatives. But if we rethink testing less as a, I have sniffles, I got to figure out if this is COVID or not, but more as a broad routine screening tool where you're going to miss some, but by the mass quantity that's being done, you're actually probably going to catch more cases than you are currently catching now. We can rethink the way we approach it. I think we could testing, and this is what I know Professor Michael Mina has been hammering the op-ed pages on, I think, since the beginning of the pandemic. This is I think a real way that you could use testing to completely reopen the economy, fully open schools, even before full vaccination rates have been reached.
Well, and perhaps we also will find with this masking that we have lower overall respiratory and GI bugs as well. So I would like to, in closing, just ask each of you, and we can begin with you, Gareth, since we're in conversation right now. Anything that you would like to let people know? We have many participants on this.
No, absolutely. And I just want to start by saying, I've seen some of the chats that come in. Everyone in that 7.1 million population that's looking for the vaccine. I get it. There's going to be a couple of weeks where it's going to be frustrating in terms of getting appointments and lining up to shots. There are sites that have been booked out through April already, and I would just ask for patience. We went from 2.1 million people eligible to 7.1 million people eligible in a matter of 48 hours. And so to the extent that these vaccines are coming, there are not going to be any left on the shelf at the end of the week, and they're going to be getting into arms. And the moment that we can get more vaccines out there, when more supply comes in, we certainly will. So I would ask for patience. I understand the frustration. My mom, I think, who doesn't even have a cell phone, spend hours of frustrated time trying to find how to schedule. So I get it completely. I would ask for patience. But in overall, Susan, I want to thank you for setting up this panel and everyone for joining us. And I hope it was informative. And I really enjoyed being part of this.
Thank you. Wafaa, any closing thoughts?
Yeah, I mean, I think in many ways, I totally understand and appreciate the frustration. I think people are a bit exhausted from all what we've been going through. But I always tell everybody, please, this is not the time to let down your guard. I think most importantly, we do have tools at our fingertips, and I call them the non-pharmaceutical vaccines. We actually know that masks and distancing works really well. Again and again, it works really well. So let's, as we're waiting to get access to the vaccine, and hopefully that access will increase incrementally over the next several days and weeks, is not to let down your guard and hold on to our non-pharmaceutical vaccine for now.
Ed?
I'm going to say 3 words while I hold up my mask: patience, science, April.
Well, thank you, everyone. Thank you, everyone who joined. And everyone, be safe, wear your mask, and be patient, and keep refreshing to look for your appointments as you become eligible. Thank you so much.
Thank you.
Good night.